So I understand that you've been experiencing some headaches and some changes in your vision recently.
Yes.
Can you tell me a bit more about what's been going on?
The headaches have been quite bad in the mornings and during the day. Been having to take paracetamol quite regularly. Also, there's been intense flashings in the eyes. Right. Sometimes even at night time when I wake up to go to the bathroom. So it's like stars flashings that's going on in my eyes.
Right. Okay. Paul, why don't we start with the headaches first?
Yes.
Can you tell me whereabouts in your head you feel them most?
Yes, right at the very front of the head.
Right. Okay. And when did you first start noticing them?
Quite a while. It's been going on for about a year now, at least a year.
Okay. And are you able to describe the type of pain that the headache feels like?
Yes, it feels like almost as if you've bumped your head on a door.
Right.
As if you've got up too soon and you bumped your head.
Yeah. Okay.
Yes.
And does the pain spread anywhere else?
Sometimes across the head.
Across the head.
Yes.
Does it ever go down to the neck?
To the back of the head.
Okay.
Yes.
Okay. And does it ever go down to the neck?
Yes.
Okay. Fine. And have you noticed when the pain is worse? Or anything that makes it worse?
Yes, sometimes when I sneeze or cough.
Okay. And is it more painful in the mornings as well when you first wake up?
It's in the mornings, yes.
Okay. And over the sort of last few months to year, as you mentioned, do you think the headaches have been getting worse?
Yes, they have.
Okay.
Yes.
And at the moment you've mentioned you've been taking paracetamol.
That's right.
Have you been taking anything else to help it?
Yes, I'm on some blood pressure tablets.
Okay.
Yes.
And if you had to rate the pain between 1 and 10, 10 being the most excruciating pain you've ever experienced,
yes,
particularly in the mornings, what number would you give it?
I would give it quite a high score, say about 9.
Okay.
Yes.
Fine. So you've got quite severe headaches. Fine. Let's move on to the vision. You have mentioned some flashes and almost like some light sparkling. Have you noticed any loss in the vision as well?
Yes, blurry vision.
Feels blurry. Okay.
Yes.
And when did you first start noticing the blurred vision?
Over about the 12 months.
As well.
About 12
so
months,
it's been
yes.
Slowly creeping up.
Yes.
Okay. And any changes? Have you noticed that you've found yourself bumping into things or missing people that have been waving at you?
Sometimes when going through a door, I've been knocking myself and I've been misjudging the width of the door and I'd knock myself on the side.
Right, okay. And fine, that must be quite alarming for you actually.
Yes.
Fine, okay. I'll ask you a few more specific questions now if that's okay. Have you noticed any change in the size of your hands or feet in this time period?
Yes, particularly my feet and my hands.
Can you tell me more about the feet?
My feet. So back in 2004, my daughter was getting married. And when I grew into adulthood, I always took a size 9 shoe. So I was looking for a new pair of shoes for the wedding. And when I went to look for new shoes, I found that I was not able to get into a size 9, which was quite strange because that was the size I always took. And my wife could regularly, sometimes she could buy me a pair of trainers for my birthday, things like that. And she gave up in the end because every time she'd get the size wrong.
Right.
So I found that I had to try and move up and maybe I went into the size 10s.
Okay, interesting.
And with the size 10s, even with the size 10s, I found they were quite uncomfortable.
And I noticed you're also wearing a wedding ring there.
Yes, that's right.
Have you had to change that wedding ring?
Yes, this is my second wedding ring. Okay. And my first one I had to have cut off. Okay. And this one's been very difficult to get off as well.
Has any of your family members noticed any changes in your appearance?
Yes, so my wife and my family would notice that when I would drop off to sleep in the chair in the living room, sort of watching television, my jawline has changed, sort of more square shape. My tongue, when I go off to sleep, my tongue comes out.
Yeah.
And terribly snore.
Yeah.
So my grandchildren were staying with us, and my granddaughter said to my grandson, "Can you hear that car in the street?" And my grandson said, "No, that's not a car. That's Pops snoring."
I see.
Yes.
Of course.
So that's how bad my snoring is.
Of course. And have you ever seen a specialist for the snoring?
Yes, I've had sleep apnea,
Okay.
and I've been using the machine under Guy's Hospital.
Right. Okay. So I'd like to explore your past medical history in a bit more detail now. Do you have any diagnosed medical conditions?
No.
No. Has anyone told you that you've got high blood pressure?
Yes.
I'll talk about your medications later, but has anyone also checked your blood sugars recently?
Yes.
And have they been on the higher side or lower side or normal?
Sort of on the highest, just sort of on the verge.
Okay. And for the blood pressure, are you taking any regular medications for that?
Yes.
Do you know which ones they are?
Yes, lisipin and alapril. I can't pronounce the word.
Okay.
Sorry.
I think it was.
Yes.
It sounds like lisinopril.
Yes, that's
one.
right.
And what was the other one? Beginning of A, was it?
That's right.
Is it?
Anaplin.
Oh yeah,
Yes, I
amlodipine.
think that's
Okay.
right. Yes.
Fine.
I'm terrible with the names of medications.
That's okay. And do you have any allergies to any medications that you
I'm
take?
allergic to penicillin.
Penicillin. And what
Yes.
happens when you take penicillin?
I believe I come out in a rash.
Okay.
Which happened when I was a child.
And do you take any regular medications over the counter that are not prescription?
No.
Okay, fine. Any conditions that run in the family?
My mum had diabetes.
Okay.
My father died of cancer of the pancreas.
Okay.
My grandfather died of angina.
Okay. And Paul, can I just ask, have you noticed any change in your bowel habit at all recently?
No, doctor, not any specific change really. No.
Okay, that's good. And are you still working at the moment?
Yes.
Have you ever smoked?
No.
Do you drink any alcohol?
Sometimes, yes.
And how often are you drinking, and how many units per week would you
Just
say?
occasionally. I don't drink that often, but sometimes if I go out, it can be about 4-6 units perhaps.
Okay.
Yes.
Okay, fine. And a routine, we ask everyone this question, but have you ever taken any recreational drugs?
No, never.
Okay, fine. Paul, I'd like to examine you if that's
Yes.
okay. I'll start by examining your vision, since that's one of the issues you mentioned.
Yes.
Have you noticed any change in the vision when you're just looking at me? Can you see my whole face?
I can see your whole face, yes.
Okay, fine. At this point, I would formally assess visual acuity and colour vision using Ishihara plates and a Snellen chart. Paul, the next thing I'm going to do is start by checking your visual fields.
Yes.
So if you keep looking at my nose, I'm going to stick my fingers up here. Can you point to my finger that's wiggling? Good. Next, I'm going to get you to look at this white hat pin now. Without moving your head, can you track it with your eyes and let me know if there's any pain or double vision at all? Keep tracking it with your eyes.
No.
Okay.
That's fine.
Next, I would like you to cover your right eye with your right hand, and I'm going to cover my right eye with my my left eye rather, and I'm going to bring this white hat pin in. Can you tell me when you can see it?
No.
And tell me if it disappears at all. Okay.
No.
Tell me again, when can you see it?
No. Yes.
Okay.
Yes. Yes.
Good. And then we'll do the same with the other eye.
Yes. Yes.
Keep that eye covered. Keep that eye covered, yeah.
Yes. Yes.
Okay. I'm going to shine a light in your eye if that's okay. You can take your glasses off. If you look at the distance behind me, I'm just going to shine this light in your eyes. Okay, and now I'm going to switch between them. Lastly, I'd like you to now look at the pencil close to your eyes. Okay, fine. I'm going to look at the back of your eyes now, okay? It's going to be a bright light, but it's not going to cause any damage, okay? I'm going to stand up at this point. And okay. And you look over my shoulder. And now look into the light. That's fine. We'll do the same on the other side. I'm going to take some hand here. And look into the light. Okay, that's fine. So Paul, I'm just going to have a quick look at your hands. Can you stick them up in front of you like this? And can you turn them over for me? Okay, I'm going to tap in the middle of your hands now, okay? Can you let me know if you feel any tingling?
Yes. Yes.
Okay. Yeah. So Paul, can I have a look at your mouth, if that's all right? If you open your mouth, stick your tongue out, okay? And then bare your teeth. Thank you. At this point, Paul, can I ask you to remove your t-shirt? And I'm going to listen to your chest and back, okay? Okay, can you sit forward for me? That's it. And take a few deep breaths in and out. Okay. Thank you, Paul. You can put your t-shirt back on. So Paul, I think I have a good idea about what's going on here.
Yes, Doctor.
But before I proceed, is there anything that you're particularly worried about?
Well, about my headaches and the flashings in the eyes I'm concerned about.
Yeah, okay.
Yes.
And is there anything that you were hoping in particular that we might be able to help you with?
To actually find out what actually is going on with the flashings in the eyes.
Okay. So Paul, I think you may have a condition called acromegaly.
Right.
What this is a condition where one of the glands in your brain is overproducing a hormone called growth hormone. To further confirm this, I'd like to run some extra tests.
Yes.
Okay. So these tests will involve taking some blood tests. I'd also like to arrange some scans of the brain. And depending on what those shows, I'm probably going to liaise with my endocrinology colleagues to arrange further follow-up.
Yes.
Okay.
Lovely.
And I think that's what we'll start with today.
Yes, thank you. So, Doctor, if it is acromegaly, then is there any treatment for it?
Yes. So we have very good treatments. There are several treatment options. Firstly, your case will be discussed within the multidisciplinary team.
Yes.
And depending on how or which option they think is most appropriate, we'll proceed. So there are several options. The most common and one that we usually opt for is surgical. And this is often a procedure done through the nose or rarely through the forehead. The second option is using medications to suppress the hormone.
Yes.
And third option, in very rare circumstances, we may decide not to do anything.
Right, I see.
And we would discuss the case thoroughly to make sure that the treatment that we feel is best for you will be provided.
Thank you, Doctor. Thank you so much.
That's okay.
Thank you.
Please present your findings and the most likely diagnosis.
This gentleman reported a progressively worsening headache, first noticed approximately 1 year ago, described as a frontal headache, worse on waking in the morning, on coughing and sneezing. This was associated with blurring of his vision and intermittent flashing lights. I further elicited a history of his shoes and wedding ring no longer fitting as they had previously done. There was no change in his bowel habit, no chest pain, shortness of breath or palpitations. In addition, he reported a history of high blood pressure and a borderline elevated blood glucose, as well as a recent diagnosis of obstructive sleep apnea. He takes amlodipine and lisinopril regularly and reported an allergy to penicillin, the nature of which was limited to rashes with no anaphylactic history. There was no relevant family history to report. He denied smoking but does consume alcohol on occasion. On examination, the patient did have enlarged hands. There was evidence of prognathism, macroglossia, and wide spacing between his teeth. There was also evidence of a mild bitemporal hemianopia. Overall, the patient's most likely diagnosis is that of acromegaly secondary to a pituitary gland adenoma.
How would you investigate this patient?
I would start with arranging some blood tests, including an insulin-like growth factor 1. If this is raised, I would perform an oral glucose tolerance test and assess for failure or suppression of growth hormone. I would also like to check the HbA1c, as diabetes can complicate acromegaly, and also assess the rest of the anterior pituitary profile, as concomitant hormone release can occur, including prolactin, thyroid function tests, FSH and LH. It is also important to assess the full blood count to check for anemia and perform a 12-lead electrocardiogram and acquire a chest X-ray to look for any evidence of cardiomegaly that may suggest concomitant heart failure. I would like an MRI of the pituitary to assess for an adenoma. If the patient did report a change in bowel habit, a colonoscopy would also be indicated.
What is the management of acromegaly?
The management of acromegaly, following on from history examination investigations, would require multiple things. Firstly, an MDT approach involving the endocrinologists and possibly the neurosurgical team. Surgical management usually is the first line to remove a pituitary adenoma, usually via a transfenoidal approach and less often a transfrontal approach. Medical management can be considered where surgical treatment is contraindicated, or if the mechanism of presentation is not related to an adenoma. Somatostatin analogues such as octreotide and lanreotide are first line, and other options would include growth hormone antagonists like pegvisomant. These patients need regular follow-up with surveillance colonoscopy to evaluate for colon cancer, careful monitoring for heart failure, and after treatment, serial IGF-1 and MRI scans of the pituitary to detect any possible recurrence.
Acromegaly is an endocrinological disorder due to excess amounts of growth hormone with resultant characteristic features. The causes can be classified as independent or dependent on growth hormone releasing hormone. Of the independent causes, by far the commonest is the pituitary adenoma. These can be sporadic or may be associated with the MEN1 syndrome. Growth hormone releasing hormone dependent causes are more rare and can include hypothalamic lesions or ectopic release of GHRH. Patients usually present with changes in their physical appearance. They may bring photographs to enable comparison. Growing taller is especially a complaint if the condition manifests before closure of the epiphyses in childhood, where it may result in gigantism. Patients may notice their hands and feet growing, resulting in socks, gloves, and shoes no longer fitting. They may notice their tongue grow, their face or jaw grow, and separation between their teeth. Excess growth hormone may also cause gynecomastia and goiter. Headaches and a change in the visual fields, a bitemporal hemianopia, may be present if the patient has an underlying pituitary adenoma. Other clinical features include a deeper voice due to thickening of the vocal cords and sweat gland hyperplasia resulting in hyperhidrosis. Complications of acromegaly include diabetes, which may be associated with an acanthosis nigricans, heart failure, osteoarthritis, carpal tunnel syndrome, obstructive sleep apnea, and bowel cancer. When examining a patient with suspected acromegaly, it is important to work systematically from peripheral to central and assess for all the clinical features and complications of this condition. One should also look around the bedside for any photos or the size of the patient's shoes. The hands are characteristically large, doughy, and spade-like. They may be sweaty, and diabetic fingerprint marks may be visible. Asking for a blood pressure is essential, as this may complicate acromegaly. A positive Phelan or Tinel's test may suggest carpal tunnel. When assessing the face, look for interdental separation, prognathism, large lips, nose, ears, a prominent supraorbital ridge, and facial creases. There may be seborrheic skin with acne and macroglossia. Check the visual fields and assess for bitemporal hemianopia or bitemporal upper quadrantinopia. The axilla should be evaluated for acanthosis nigricans, skin tags, and the neck should be examined for a goiter. The abdomen should be ideally palpated for organomegaly, especially if there's a history of change in bowel habit. The chest should be examined for gynecomastia and auscultated for pulmonary edema. Assessing the legs for peripheral pitting edema, any proximal muscle weakness or osteoarthritis are possible ways to conclude the assessment. Investigations are usually with blood tests, in the first instance with an insulin-like growth factor 1, IGF-1, as a screening test. If this is raised, a confirmatory oral glucose tolerance test assessing suppression of growth hormone is performed. In patients with acromegaly, growth hormone is not suppressed. It is also important to assess the remainder of the anterior pituitary profile, as concomitant hormone release from an adenoma can occur. For example, thyroid function tests, prolactin, FSH, and LH. Screening for complications including an ECG and a chest X-ray for heart failure, a HbA1c for diabetes, is essential. Imaging with an MRI pituitary should be considered. Surveillance colonoscopy is required in these patients due to the risk of colorectal cancer. Management usually involves surgical removal of the pituitary adenoma, usually via a transsphenoidal approach. Medical management may be an option if surgery is contraindicated or if the cause is not a pituitary adenoma, such as with a somatostatin analog like octreotide as first line, or a growth hormone antagonist, pegvisomant, as second line.